I've been asked to talk about e-health in South Africa, and that's a daunting task because on the one hand there's so much to tell. On the other hand, there's very little to talk about, and that sounds odd, but hopefully it'll become clear to you as I go on. For those of you who've forgotten your basic geography, we're down the bottom end of Africa. We've got a population of just over 52 million. We're divided into 9 provinces, and I'll come back to that a bit later. About 40% of our people live in fact, rural areas, and about 14% survive on less than $1 a day purchasing power parity. In fact, government spends about $230 a head a year on health, and that's to service the in fact uninsured. That's in fact 82% of the people. But the in fact actual facts are that 60% of the total health spend in the country is spent on the 18% who are insured. As you can see, we have a shortage of doctors, as does everybody else. And unfortunately, governments of health in South Africa has devolved from the National Department of Health down to the 9 departments of health in each of the provinces. And they can act independently, and they sure do. So, e-health, the use of information communication technologies in health. And as you'll see, a broad spectrum of activities from, in fact, robotic surgery, home, in fact, monitoring, etc. But also within that definition is the whole field of health informatics, EHRs, etc. And that is a whole area that I am not going to talk much about except for the following slide. E-health in South Africa within the state sector falls under the National Health Information System of South Africa Committee. And there are information systems in the large state hospitals, but of course the 9 provinces didn't speak to each other. So there are 5 different vendors, there are 13 different variations of the software, and it's not interoperable. Virtually every private hospital has a health information system, as do the insurance companies, and virtually all radiology is controlled by an information system, as is in fact the pathology, both in the private sector and in the national health labs. We've got a district health information system which has in fact migrated, or in fact over into an IT format, and there are HIV and TB databases in fact all the provinces which we're attempting to have scaled up. So, on to the area that I feel most confident about. We began telemedicine probably back in the late 80s when we linked the early CT scanners back to in fact medical school. The National Department of Health then formed this National Health Information Committee, which is made up of the chief information officers of the 9 departments of health and some senior members of the National Department of Health. They then set up a task team to set up telemedicine, which was duly launched in 1999 in 6 provinces to in fact 28 hospitals, and it failed spectacularly. Within 18 months, all but 1 radiology service was in fact still functional, and that was functional because of the interests of 1 neurosurgeon who didn't want to take patients that he thought in fact could be managed on site. In fact, thereafter we went into the depths of depression, and in 2006 we attempted to form a National Telemedicine Association and were actively blocked by a senior member of the National Department of Health. The Department of Health then attempted to draft law for telemedicine, very restrictive, based on the, in fact, Malaysian Act of in fact, 1997. Whatever you do, don't go that route. The first steps of draft ethics for the practice of telemedicine, in fact, was circulated in 2008, and I'll come back to those. The first drafts of an e-health strategy, a telemedicine strategy, etc. And in 2011, the formation of an e-health subcommittee of a ministerial advisory committee on e-health. And I chair that, and I can say that we have achieved 0. We were fortunate enough to eventually get the South African Telemedicine Association going in 2011, but there has been some success. We do have a national e-health strategy, which is very important because it is the foundation of everything going forward, and that was launched at the end of in September of 2012. The first sequel of that is that we actually have a national health normative standards framework for interoperability. So hopefully the problems that we've faced in the provinces will go away over time. But I think that's actually a very important first step. The National Telemedicine Strategy, and you'll see the date there, October 2012, still hasn't been, in fact, launched. It's lying on somebody's desk in the Department of Health. The same as the M-Health strategy for South Africa, still hasn't been launched. The Health Professions Council in South Africa is a statutory body that licenses doctors, and it sets the in fact, ethical and practice guidelines. And in a way, they have probably been the biggest obstruction to telemedicine in South Africa. Why? Because they make dumb statements. Phone doctors under fire. Telemedicine unethical, says the Health Professions Council. HPCSA condemns telemedicine. They didn't condemn telemedicine. In fact, what they did is they didn't like the way the private practitioners thought they could earn something out of telemedicine, but all of these went into the papers. They have eventually, after 8 years, finalized their guidelines. It's going through the process of being approved with, in fact, all the boards within the HPCSA. And it's a starting point, but it still needs plenty of work. Why? Because they haven't defined the words shall and should, and it causes a major problem. Because where something shall be done in one section, it's referred to somewhere else as being should. And so we've got a long, hard fight ahead of us there. Shall we interpret to be mandatory? Should. We're interpreting to say, well, if you can achieve that, that's good. As part of the build-up to the National E-Health Strategy, the National Department of Health undertook an undertook a telemedicine audit in 2008. And they identified 86 sites, of which they said 32 were active. In fact, note the word sites. They don't talk about services. They don't talk about use. They're talking about, is there a video conference unit? Is there an X-ray machine hooked into a service somewhere? And there was zero data on use. In fact, store and forward services weren't counted because they didn't involve big infrastructure, and there was no mention of, in fact, telemedicine. So in the middle of last year, we decided we had better update this, and with the backing of this advisory committee and the National Department of Health, we sent a questionnaire to the 9 departments of health, and we asked the National Department of Health to please identify who the telemedicine coordinators were that they were dealing with, and we sent these off. First thing we get is, in fact, 3 of the 9 people say they've got nothing to do with telemedicine at all, and there's nobody in their ministry who has anything to, in fact, do with it. So that's the first 3 out the way. Of the other 6, we got answers from 4. In order to actually determine the full scale of work, we then reviewed all of the annual reports and the strategic plans of the 9 departments of health, going back to 2000 and going forward to their plans forward as far as in fact 2 years hence. We also, in fact, reviewed everything published in the medical journals on telemedicine in South Africa in an attempt to get a far better picture of exactly what was going on. And it was very sad that there's very limited data on the number of services and the number of cases seen. And without data, you can't manage anything and you can't go forward. So our findings, of the 433 state hospitals, there is infrastructure in 131 of them. We believe that about 100 of these sites are actively being used. The clinics, there in fact isn't that much going on. In fact, there is no data on informal services. So there are doctors in hospitals putting out their cell phone, in fact, taking a photo of a skin lesion, sending it off to a dermatologist, they get the answer. There is no record of that anywhere, and that makes life, in fact, very difficult. These were the services that we found. The 4 highlighted, we in fact actually have data on the, in fact, number of cases, the duration, etc. But all of these were out of academic departments in a medical school. Right, we get on to M-Health. Everybody says M-Health is going to solve the problem. It'll make everything go away, and the GSMA have a world map which shows the number of in fact, telemedicine in fact, activities going on. And in fact, India comes third with 66 after South Africa at 96, behind the States at 195. And if you go onto those buttons and you hit the button, you will get the detail of everything going on. And I just want to make a final point here, that there is so much hype. The Gartner hype curve. Where on the Gartner hype curve do we think we are at the moment in terms of M-Health? Well, in 2011, that's the most recent report, it's up there. So we've got some deep, depressing times ahead of us as we strive to get M-Health going. The one thing that has worked, it's worked in South Africa, it's worked in most places in sub-Saharan Africa, is education. Doctors want education, and if you can give it to them that they stay at home, and they get it when in fact they're at home in a different town, they are very happy. And so I've summarized the activities we've been doing since 2001, the number of hours of teaching by video conferencing each year, and we're averaging between 35 and 40 hours a week each week. In order to go forward, you must do, in fact, research. And so we searched Scopus under a number of keywords for, in fact, health informatics and keywords for in fact, telemedicine. We found some 75,000 papers, of which South Africa has contributed about half of 1.2% in terms of telehealth, and about a third of virtually nothing in terms of medical informatics. So there is work going on, but it's not being documented, it's not being in fact reported on. So in fact, finally, where in fact are we? I believe the governance issues are being raised. We've got a strategy, we will have further strategies. I think we're putting all those pieces in place. We need to get buy-in from the departments of health in the 9 provinces. We need to evaluate, monitor, report, publish. We need to understand what's going on in the private sector. We see spontaneous services be starting. We need to develop an enabling environment. But the message that we keep saying at these conferences over and over and over again, we've got to raise awareness everywhere. It isn't just in the Ministry of Health. It isn't with the doctors. It's with the end users. The patients must be demanding it from us. But otherwise, we won't get to that point where the specialist is working from home, basically in his village, and he can do everything. His cell phone to his ear, working on his computer, and he is happily doing it. In fact, thank you very much.